But it was kind of like he was holding it like at a U and, bent it the way it doesn't bend. I don't know.
Just to test it, or
PMA bridges really and tried to break them before. Are they breakable, the ones we get from Gladwell?
They are, but I would imagine 3D printing, because it doesn't go through, I don't know, is there a post-curing process?
I mean, that's what I did. I mean, we could.
That's what they're doing.
I made. Well, I printed two more because the first one came out real chalky, and it was weird. The second one came out actually chalky also, and I polished it all off, and it was fine. But I went at it with the polisher and everything, and I actually accidentally hooked it across the lab at one point. I hooked it just the wrong way. It didn't break.
Yeah.
So.
Did you tell him I snapped it in 2 seconds?
Yeah, I told him I snapped it. And he goes there. This thing sucks. Now he's
48 minutes of wasted.
I know, right? It's like, man. Nah, it was good. Good it happened, because now we know, I think where it snapped, I mean, she's got really tiny teeth. And if you're looking at that video where I spin it around, you'll see there's 2 points that are really thin. So one option is to have them redesign it where it's thicker, or for me to just etch bond and flow those spots and just bulk it up in those areas. But I need her model first so I can put it on that. I'll print that tomorrow.
Sweet.
Oh yeah, that's a good point. You can test it out on the model.
Yeah.
Hey, Chris. Does everybody know Chris?
Yes.
Chris is one of Dr. Labonte's good friends. He practices down in Florida.
Oh, cool.
Can you guys hear me okay?
Yeah.
We can hear you fine.
All right. Sorry, I got these Bluetooth headphones. Can't figure it out. Killing me.
You're an old soul.
Yeah, I know. I met Luke. I think Jordan, we met for a minute. Jason, I think we met too, right? For a minute?
Maybe. I don't know if I recall.
All right, it was a whirlwind day when I was up there, but
yeah.
How you guys doing?
Good.
Doing good.
Still got snow?
No, it's gone.
Kind of rain. It rained and washed it away.
All right. Well, it's about 75 degrees down here, so it's pretty nice.
Nice.
Not to rub it in. I missed the skiing, but.
Dr. Roy didn't miss much on the skiing on Sunday. It was not great.
Yeah, I heard that it started raining.
It did. When Mark and I were coming down the mountain, it was we had a couple spots. I couldn't actually see the dips that were in front of me, and all of a sudden I was like, "Oh, I guess I'm falling. Here we go."
Oh, geez, yard sale. I wouldn't want to see a yard sale of you coming down the mountain.
I know, it's funny. I made it all the way to the bottom with him, and then I hooked wrong when I was stopping and wiped myself out, turned myself into a pretzel at the bottom of the hill.
The CE was good, though, at the Learn at the Loaf?
It was pretty neat. It was interesting. Actually, the thing he texted us today was from the CE that we had.
Cool. Okay.
With the
buckle roll?
Yeah,
the paddle roll?
The paddle roll technique, yeah.
Yeah, it's basically similar to the idea of, it's the same idea, really.
Yeah, the pictogram looks like it takes more of the palatal, but...
Exactly. I'm trying to find, does somebody have a copy of, you think I would have come with this. I thought I had it. The treatment plan P2, the one that we do all the treatment plans on?
I mean, I can find one.
I have 100 of them printed out. I mean, I'm looking in the shared drive right now. Let me look at this another way. Treatment planning. I got it.
Yeah. You say the only way I get one is a remote in, so.
Who is able to type if we have something, if I just ask somebody to write something down so that I don't have to get too many lines?
Give me a sec. Hold on.
Who would like to be our sexy secretary for the evening?
I'll do it.
I knew you would.
Jeez. Hold on, let me.
All right, now we're good. What's up, Doc Stock?
What up, what up?
Yeah. There it is. You know, if I still drank, I would totally have a frosty cold adult beverage myself.
Right? It's
Instead,
a good time for it.
I have a Kai powder infiltrated blueberry tea.
Oh, it's good.
Because I'm old and I need my antioxidants.
A lot of antioxidants.
It's great.
All right, let's go ahead and get started. I'm going to go ahead and share my screen. So I'd assume everybody knows what the goal of this particular mastermind is. It's really to talk about treatment planning, not necessarily execution. We're probably not going to talk about palatal roll technique and crazy things like that. But we can bring it in. We can talk about it. But the focus being on being able to assess cases well and provide good treatment. So let's start with Mr. Marcel here. So what are 3 options for this guy? Just quick, let's start off with that.
Upper complete denture.
All right, that's one. Anybody else?
Like a partial. I mean,
all right, RPD.
Probably not something you could do. On 4.
All on 4.
Love it. Try to post and core, or root canal post and core those. Crown lengthen them a little bit. Do a nice bridge there. Long-term prognosis, fair to poor.
All right. Anybody else want to provide some insight here? The whole goal of what we're going to do is to never provide solutions until we have all of the problems. So I set you guys up. I'm sorry.
Ooh, good point.
So what I want to do, I created this NECADE diagnostic checklist. A few of us have talked about the idea of having a almost automated maybe not automated, but something where we can log in and simply check off specific problems that exist in most patients. And I started kind of categorizing them based upon different categories. So I'm going to just read what I wrote here as the introduction. The algorithm here is meant to provide some clarity to the broad set of conditions that show up in the patient's oral cavity and related structures. From this checklist, we will construct the problem list. The goal of our treatment plans will be to assess how our treatment strategies, we're going to replace treatment options on page 2, which we'll go over the specific pages, but using the word strategies, I think, has more leverage and is more accurate in what we're trying to do. So treatment strategies address the items on the problem list. All too often, treatment plans start with solutions. That's how we're taught. So I did it for 15 years. Don't worry about it. I just wanted to provide some contrast in how our brains normally think. We see missing teeth and we automatically want to start filling those holes. As we know, we've all done treatment plans where we take a step back and we realize that the solution that may have been obvious to fill that one hole didn't play into a bigger picture. And that's really what our focus is tonight. So we must start with the problems so that the patient can own the problems that are not addressed. For example, if a patient chooses a partial, not only do they solve most of the issues, but they introduce new ones, such as food impaction, aesthetic compromise, and what have you. These trade-offs need to be highlighted during the NECADE treatment planning process. If we gave a patient a partial in this situation here, we don't really paint the picture to the patient that they're choosing a lower level option. We've all, I say we all, in my career, I've done many partials, And the patient's response after it broke, or I couldn't get the framework to fit well, or the teeth didn't look right in their face, all of the challenges we have with removable, the entire time I'm thinking to myself, this is a bottom of the barrel option. Meanwhile, the patient's like, that's all I could afford, but I thought I was paying for something that was great. And what I found is this particular process inherently undoes that, because it speaks to there's a hierarchy of options or strategies for these patients, and the hierarchy solves the problems accordingly, and sometimes they don't. So as we create treatment strategies, we're always going to come back to our problem list and ask the question, did we solve all of these problems? Many of you guys I've seen you guys start putting together your treatment plans that you send to TIFF, and I can see in the verbiage in the pros and cons writing that includes all of the problems are addressed, or some of them are addressed, not all of them are addressed. I think that verbiage is our ticket to safety when it comes to the patient getting upset in the future. So a lot of this, the way we constructed this, is to avoid headaches down the road. But coming back, it's the problem list that we're going to start with. So I then put, this will become automated at some point. Diagnosis shouldn't take long. At the end of the day, an automated diagnosis is still better than the chairside diagnosis. I'm going to try to not be condescending when I say chairside diagnosis, but that's what the bulk of the industry does. They come in during a hygiene exam or a new patient exam. Patient presents with a problem, and we try to provide a diagnosis in 5 minutes. I'll be the first to admit I'm not that good. Maybe some people are. But at the end of the day, I think taking a step back and doing what we currently do, and I think everybody here would agree, getting all of the data from Chantel's diagnostics appointment provides a moment for us to really look underneath the hood and make sure that we're checking all the T's and dotting the I's. So before we go down this list, sorry, Jason and Ryan, to set you guys up, but that was beautifully done so that we could articulate the point. What are everybody's thoughts here?
Hey, Doc. I think that we could all agree that we all mention how much partials suck, whether it's during a consult visit, whether it's on the diagnostic forms or the treatment option form, or during like a hygiene exam when someone comes in for a comprehensive and they don't sign up to do records or diagnostics. So I feel like sometimes when it comes to the partial question or issue, when someone's unhappy with a partial, a lot of times it's because that was the patient that opted not to do records or diagnostics. And we were just like, oh, well, you don't want to do this, so we're looking at a partial, and those suck.
Yeah. For many years, I didn't have the clarity I have now to make sure the patient understood that. So if we're doing that, that's great. And if there's ways for us to take those patients that don't do diagnostics and they just go forward with the most inexpensive treatment, that we make sure that we articulate that in the notes and maybe have them sign a consent form. We could definitely figure out a way to make sure that we cover the same bases. But when it comes to comprehensive treatment planning, I think this process allows us to do that. Yeah.
No, I do too, and I'm not arguing that. I just and I like the idea of consent forms, and me and Jason were talking about one the other day for a patient that he had. But yeah, sorry, go ahead.
Yeah.
I think the most frustrating thing is like you go through the whole thing, you work up a treatment plan, and then they pick the least expensive option. It's like, I don't know if it's either I'm just not good at selling treatment yet, or, the way that I talk about it maybe is not as confident as I will be. You know what I mean? I don't know if that's been my experience on, a handful, but I don't think that's to say that, partials don't have a place, but I think, that's a small price to pay. $390, whatever we charge, that's a small price to pay for the whole menu of options, at least. So
one of my most proud cases, and I've shared this with many of you along the way, was when a patient chose the partial. It was an all acrylic partial with an upper complete denture, so lower all acrylic partial, composite on 22 through 27. This lady is a multimillionaire, and she chose that option, and I'm proud of that, because the goal of this isn't to get patients to do comprehensive care. It's to be very honest about what their options are. And if we do it well, we will do more comprehensive dentistry, which is fun for us. But this isn't about getting $40,000 checks every week. When that happens, am I excited? Absolutely, but that's not why we're doing this. If it was, then we would take some of the courses that currently exist out there on how to close the patient, so to say. This isn't about tricking a patient. This is about presenting them the options so that they have the clarity that they will not have when they're chairside. You know, we know when patients come in and they sit down in the dental chair, they're coming with anxiety. God only knows what happened during that day. Gas prices are high. All of this emotion comes in, and then we come in and we have 5 minutes to tell them that their entire life their teeth have been screwed up. What we're trying to do is spread out that process over time so that they can gain some clarity and make a better decision. If they end up choosing the partial, they're going to choose a partial and they're going to own the downsides to a partial, but there's nothing more gratifying than making a really good partial. So again, this isn't about top-end treatment. Ryan, do I think over time you're going to get a better conversion rate to patients choosing something higher on the list? Absolutely, and that's why we're doing these events, once a week. It's all about growth. It's all about confidence. It's about painting the picture for the patient. It's the psychology of the words that we use in the documents. So there's lots of little things that we're going to talk about over time that's going to help you get patients better treatment. That's what it's all about at the end of the day.
And Ryan, I just want to add an addendum to that. Just with the patients that you put in a lot of effort for, and you feel that perhaps it hasn't come to the fruition that you envisioned. I mean, one thing that Nick has said, which I love, is number one, we're putting them in the queue of patients who are going to come back in a couple of years, and then they're going to go for what's really the more ideal option for them. The other part, for me anyway, is that the second I really, I don't know how to properly articulate it, but the second that I stopped being so focused on, I want them to do the diagnostics because I can see all the possibilities, and I just presented it to them as, if you want to do this, I think you should. But just not being so focused on getting them to do it. Those patients who want to follow through, even when I'm putting forth like that truly neutral effort, those are the patients that I find that really want to take the next step. Like if I have to work on a patient to convince them why they need it, I think I'm probably not doing what they need. They probably just need me to give them the 2-minute comprehensive exam that they came for.
Yeah, I would second that. And especially like I focus a lot on the problems, like Dr. Roy is trying to get us to do here, and automate that. Like when I show them the pictures and I'm, and they can visibly see that things can't continue the way they presently are going, that's when I have success as well. But yeah.
Great.
You guys, do you have a format for, like, I mean, Christian's explained to me that you have patients who you set up for more in-depth diagnostic appointments, right?
Yep.
Do you write up a diagnosis list and then you even like, here's your treatment options. This treatment option hits these diagnoses, this treatment okay. So yeah. Okay, I would think that would be a pretty, not even a covering your butt, but like if you're going to go for the lowest tier, then these are the things we're going to solve. These are the problems that you're still going to have, almost like just a checklist. Yeah. This is just, in my world, that appointment doesn't exist. I get 10 minutes with a patient. So I'm just trying to understand that.
Yeah. So this is a can you see my screen?
Mm-hmm.
Yeah. So this is a copy of our treatment planning workup. So in a nutshell, when we're doing new patient exams or even existing patients, and we feel that they have a set of circumstances that are above and beyond what we have time to really thoroughly plan chairside, we have them come back and they see we have an assistant named Chantel she spends most of her day doing this and Invisalign. And what she does a full set of photos, a CAT scan, a couple videos for kind of functionality reasons. What am I missing, guys? It's basically a full data acquisition. And then we take that and we fill this out. So this is the first page, which this is really what we're talking about tonight, is creating the problem list. And then the second page is the strategies. We call them options right now. I want to change it to strategies. Options are specific. Strategies are kind of ballpark options. So we might have strategy 1, which is typically removable. So that would include partials and dentures. We're not trying to get specific at this point. The goal of this is to get them comfortable with big numbers and understanding that their problems, in order to get solved well, is going to be expensive. We're not looking to get them to understand exactly what it's going to cost. We're not pre-submitting to the insurance at this point. We need them to tell us, yes, I can afford $5,000, or yes, I can afford $50,000. And then the final page is what's called the phase plan. We do this early on to show them that all treatment can be phased over time, and that's really where a lot of our power comes from as a practice. We use long-term provisionals to help us get kind of through the weeds of complex cases. You know, when you have a full mouth rehab, getting them to an all-on-4 is easy. Getting them to save 5 teeth in an arch and then put grafting and implants in between, that's hard. So to get there, if the patient wants to keep their teeth, we need to phase it, and we'll definitely have other sessions on phasing treatment. But we make sure to articulate that so the patients can see, oh, I could spend, money over 5 years. I can afford that. And to be honest, this one page is the reason why most patients sign up. They understand that this is a long-term commitment that fits within their budget. So that's the treatment plan workup in a nutshell. I want to go over to this diagnostic list here. So quickly, I've done several versions of this, and maybe you guys have your own. Over time, I want to create a kind of a master document. This isn't anything new. I think Kois has something similar to this, where he breaks things into different categories. I haven't taken Kois courses, but I've talked to a lot of people who have, and I have an idea of how he does things. I do think he's probably the closest to what we're going to be trying to do, but he doesn't have a strong airway component. So as we build NECADE, it's going to be kind of taking the best of all of them. I think Spear has the best aesthetic perspective when treatment planning. I think Kois has the best functional, and I think neuromuscular LVI world takes the muscles into account and gets us much closer to where I think the maxillomandibular relationship should be. So quickly here, occlusal classification. When we start treatment planning cases, we want to ask ourselves, is the patient class 1? Are they class 2? Are they class 3? What's their overbite, their overjet, their deep bite? Do they have entrapment? Caries assessment? We don't think this way. We just look until we see a problem, and we write the problem down. Well, when you take your car to the auto body shop, they hook up a computer. That computer downloads all of the problems based on some algorithm. That's kind of what we're going to try to do here. Many of you have heard of the book Checklist Manifesto, one of my favorite books of all time. The whole idea is to automate things where we're likely as humans to make mistakes, especially in the highly emotional state of a dentist practicing in the day. If you're treatment planning and you had an upset patient 5 minutes before, do you think your treatment plan is going to be as good? In my world, the answer is no. I get rattled and I don't think as clearly. So I want to try to automate it as much as I can. If I have a checklist and a sequence of things to go through, even if they don't have a problem, they can have a perfect dentition, but I go through this, I might pick up something like, well, their PSR score is a little high. What are we going to do there? Gingival Biotype. We rarely think of this. Everybody knows what it is, but how many treatment plans have you done where you took the gingival biotype into the decision-making process? That's what we're going to do, and I can promise you it's worth it. What if you had a patient that had pulp stones or obliterated canals? What does that tell you about the patient's overall status or state? Biomechanical classification. This stuff is overlooked. I mean, I've been part of a Spear study club for almost 10 years, and we do a lot of treatment planning together. And whenever a new dentist comes in and they give feedback on treatment plans, the wear and the attrition and the erosion is never built into the equation. You know, that biomechanical issues are rarely considered when treatment planning. And then we all know the importance of the airway and the things that we can see when doing an exam, the Tmd assessment. You know, we got to bring this stuff in. It's easy to overlook, but in the everyday GP practice, dental school, we're taught to treat maybe 3 things: perio, caries, and there was another, you know, maybe just general wear, you know, obvious wear, chipping and fracturing, what have you. And then there's things like medical history considerations. How many people look at the medical history when they actually do the treatment plan? I didn't for years, so I'm just going to say I assume people don't because I didn't for a long time. Sorry if you do, but I think it's an important thing to make sure we have as part of a checklist. We all know diabetes. I mean, I don't need to go down that road, but that's important. All of this stuff needs to be thought of before we start thinking about the solutions. Psychosocial considerations also being there, or just psychosocial considerations. What does everybody think about this? You know, is this overkill? It would be if you were sitting chairside, but if you're treatment planning and you have an hour to really thoroughly get the patient what they need, is this helpful or is this overkill? And I'm okay if this is overkill.
I mean, I wouldn't call it overkill. If you're sitting there and you're stuck, or if you're having a busy day, you just look at this and it gives you a prompt. I mean, it gives you something to look at. Obviously, when we have this modified so that it's, you know, in some sort of software, it'll be even easier. We'll click the problem list and it will give us an automated, the diagnosis, rather, give us an automated treatment associated with said diagnosis. But I mean, it's a prompt for keeping you on track as you go along. I don't think it's overkill.
Yeah.
Oh, sorry, Jordan.
No, you go ahead.
I was just going to say, is this something you want us to do with the patient there? So, like, obviously not during the... Okay, so do this with all of the data that we gathered from before.
Yep.
Okay. And then if there's something specific we just can't get, then we could have them come in for a quick little...
Honestly,
I need to measure this.
If there's something that might happen, let's have Chantel acquire it. So a good example is...
Like, what about Mallampati score? You know, like, I can't always see that on the... Well, we can look at the CT, I guess, you know, some of those things.
As we use more and more of this, if you guys ever have a situation where there's a data point that Chantel could have acquired that she didn't, you know, it's inefficient to bring a patient back just to look at that. Obviously, if you need to, but let's get good at just acquiring it with everybody. And here's a common example of a situation that arises that we have not yet solved. Patient has attrition on 8 and 9, and we all know the rest photo is the beginning of all treatment planning, at least from an aesthetic perspective, and we can't see the teeth. Well, we don't know how far the incisal edge is in relation to the lip at rest. Luke is brainstorming on creating a ruler that he'll 3D print that Chantel will put that'll have little marks that will show us exactly where the incisal edge of the teeth are in relation to the lip at rest, so that we can then determine where the new full mouth rehabilitation incisal edge needs to be, because that's where the whole case starts, just like a wax rim. So we're kind of using this little tool like we would use a wax rim, kind of more ethereally. You know, the concept isn't necessarily exactly the same, but we're doing the same thing. So if there's anything like Mallampati, I'll have Chantel start taking photos of that. I think that's a good one.
So I like to, before I overwhelm myself in the treatment planning process, I start every conversation by asking what the patient's wishes, desires, and goals are. And that's how and that's how I kind of tailor where this treatment plan is going to go based upon the diagnoses that I find. At all consults, like, I talk about, like, airway, the entire nathologic system, muscles, joints, teeth. That's always a part of every conversation, and it just kind of obviously goes from there. And as we address, because most of the patients have these occlusal issues. I think automating it, like you're saying, as far as the checklist while we're working these things up is brilliant.
Yeah.
But yeah.
Yeah, and maybe we have an intake form that has just what you said, wishes, desires, and goals. I wrote that down because I like the kind of 10,000 foot view perspective of such it's not non-emotional, but clinically unrelated words. On our medical intake form, we do have something, I think it says, what do you think about your smile? Which it gets us in that direction, but I think we can get better at asking the right questions early on. Now, Jordan, I agree. You are very thorough in asking it, but I want to make sure we create a process that for those of us that maybe aren't as thorough, or maybe some of us are having a bad day, there's something for us to fall back on that will make sure it gets done regardless. And in the book Checklist Manifesto, he talks about the checklist for airline pilots. And airline pilots do the same thing every day. They know exactly what, buttons need to be pressed and levers need to be switched on or off, but they have a checklist. And even if they flew the airplane in the previous leg and they completed the checklist, they have to complete the checklist again, even if they never even looked at the panel. Maybe they accidentally hit it. There's all kinds of things that can happen. And the rate of airplane crashes as a result of the pilot messing up is negligible. And I think we all know that, which is rather astounding considering flying's pretty crazy to think that we're capable of doing that as humans. So automating it as much as we can. So as we all are using these tools over time, if there's something that we can add to make it a little more automated, we do that. And automation doesn't mean we're taking out the human component of our treatment planning, but we're just making sure that we don't miss any steps to make sure that we're treatment planning well. All right, so let's switch over to Marcel. When we're treatment planning, we're looking for problems right now. Let's start with this photo here. There's no tricks here, guys. What's one obvious thing that we sometimes talk about that we can see in this photo?
Looking for asymmetry.
Yeah, his shoulder position.
Yeah, so his shoulders are uneven. His neck is tilted to the side. So there's just a postural asymmetry is maybe what I would describe it as. I mean, there's different ways of describing it. These are patients that go throughout life like this. And granted, we're not necessarily going to try to solve this. We're not chiropractors or physical therapists or orthopedic surgeons, but it's helping us understand what the story is, which is this guy's entire system is out of whack, which means there's a high chance that his nathologic system, which is the muscles of mastication, the muscles of swallowing, and the muscles of breathing, all of that nathology, which involves the joint, is likely also awry. So when we see this, we do want to make note of it. And it provides value to patients if we're telling them this, because they've never, at least I've never met a patient where I brought this to their attention where they're like, yeah, my last dentist said the same thing. Anytime we have an opportunity to set ourselves apart by helping patients become more aware of their problems, the better off we are. What's one other thing that we can see here? So his reverse smile line at lip closure is a strong indicator for loss of vertical dimension. We'll take a look at whether that happened or not. These patients often have angular chylitis due to pulling of saliva at nighttime, especially if they're mouth breathers. That may not bother the guy aesthetically, but again, it's something for us to take a look at because it paints a picture of what the problem is. All right, what about here? Is there anything new that we didn't see in the previous photo?
Missing teeth.
Missing teeth. Yeah, absolutely. This is a patient of Dr. K, the practice we bought in Livermore. Dr. K is a very good dentist, so I think most of this guy's mouth over the years was well maintained. Probably wore a night guard, and this guy's 83. other than what he broke, things are pretty good. These teeth are obviously in the right place. The only thing I would say is his nose, his nostrils are asymmetrical. I don't know if I'd attach any value to that, but do look at the nose at these photos. What about here?
Posturing his head forward.
Which might tell us what?
I'm going to let someone else answer.
Well, he's got a large neck circumference, and
Yeah.
he's just that classic sleep apnea patient. Yeah.
So this guy is not diagnosed. I asked him, and he says he never sleeps well. I mean, it's just amazing when you see somebody like this, how this guy shows up at a physician's office, and the conversation never came up. Yeah, he's a sleep patient for sure. So forward head posture is a compensatory mechanism that we do to open our airway when we're standing upright. What I typically look for, and I read it somewhere, and I don't know how accurate it is, but the middle of the shoulder and the ear should be in line. If they're not, if the ear is forward to that line, then you're likely compensating forward. Who can guess the size of his neck, just to provide some insight? 18 millimeters is where the risk factor has a significant uptick in the curve.
It's Libby sized.
Probably an 18 or 19 neck. I'm an 18 and a half.
Yeah, Luke, you come out of the shadows. I gotta see yours.
I just do this to him. I get a good idea. No.
Yeah, he's well above 18. I would say 20. I mean,
I'll say 20.
Yeah, he's a big one. So I don't know, but maybe we have Chantel measure the neck. I don't know if that would be abrasive, but you know, it's,
You know what I mean?
these ideas we need to think about.
Yeah, I think I don't know about the measuring of the neck. I think we could just say that he's in the high risk category based upon relative large neck.
Yep.
Maybe what we need to do is, I don't know if Chantel, I don't know what Chantel knows or if she has trouble assessing people based on neck size, but there's enough variety in the office. We could almost have her just look at different people in the office and kind of like go through what does she
Right.
think, big neck, small neck.
Yeah.
Can there be a board behind the patient when she's taking photos that has measurements?
Yeah.
And then based on that, can you? And, some of it has to do with how far they are, but also she could say anyone that comes through diagnostic gets a free jacket, and we have to measure them for it. So, just like a trick them into.
Not a bad idea. So yeah, over time, let's start kind of bringing these ideas in. Dentally, let's take a look. What do we see here? Obviously missing teeth.
Patrician,
Where?
recession,
Cracked teeth, abfractions.
Bone loss.
Does he have a collapse VDO though? And how do we know?
Why don't we save that conversation for another day, because they would probably eat up the next 20 minutes. But that is a good question, Zach. It's like, how do you know? I'll just say I don't think so. I typically look at the posterior CEJs. Those are pretty tall. I would say he's not collapsed. He doesn't really seem to have any compensatory eruption of 8 and 9. I mean, maybe a little bit here. If we draw a line. Let's quickly go over compensatory eruption, because it's mildly related to this concept. Who are the patients we are most likely to see compensatory eruption on? There's two categories. Give you a hint. The first one is in a dental classification. Class 1, 2, or 3 patients.
class 2.
Yeah. And why is that?
Lack of contact from the opposing arch.
You got it. So class 2 patients, the anterior teeth. Well, class 2 div 1. Class 2 div 2, you might have contact in the anterior, but class 2 div 1, that patient has excess overjet. So something like this. Trying to get the camera right. There we go. And because of that space, the upper teeth erupt up and the upper teeth come down. That's compensatory eruption. The eruption occurs to compensate for the malocclusion. Teeth erupt for the most part until they come into contact with an opposing arch. There are exceptions to that, but in general, when you see compensatory eruption, and Chris, if you've never heard that term, compensatory eruption is when the maxillary or mandibular incisors are on a different plane than the plane connecting the canines. So if we come down here, there's some degree of compensatory eruption. The reason why this is important, this is emphasized in the world of SPEAR. It helps with treatment planning because you often want to get the patient back to where they should be. Asking the right questions allows you to then figure out what kind of treatment should be rendered, which isn't the goal of today. But when we say compensatory eruption, we're talking about the fact that the anterior teeth erupt towards each other because they don't come into contact. What's the other scenario that this happens?
Just like the severe wear patients, like the severe bruxer.
Yep. So there's different, and you're spot on, wear patients. There's different kinds of wear patients. You know, we'll probably bring a lot of that SPEAR stuff in because SPEAR does probably the best job breaking down the different categories of wear patients. But the patients that do this, you know, they grind on their front teeth, the horse grinders where they're going back and forth like this. Those are the patients you tend to see compensatory eruption. They're also the patients that are very difficult to remove teeth because their bone is so dense, because they're bone compensated, the density of their bone compensated. Anything else in this photo that we can see? I mean, obviously, I don't know if we want to call these abfractions or recession or both, but, you know, root exposure. You know, maybe some inadequate hygiene. The moment this guy goes from proper salivary production to inadequate salivary production, this is going to be destroyed. We know that. The treatment plan I'm going to present the guy is going to be, we can cover this and decrease your chance for caries. Is that a reason to do a full mouth rehab? No, but it's a very strong supporting reason to do a full mouth rehab. So pretty much the same here. When Chantel takes her photo, she sometimes the cheek gets in the way and blocks the light from getting out back here. It's hard to do well, but it's something that I do work on with her. What does somebody notice here? $27, $28, $30. So I don't know if this guy had a congenitally missing tooth, but missing teeth is a common thing that's missed during treatment planning. Central incisor, sometimes we have extra ones, sometimes we don't. Or sometimes we're missing a central incisor. Looks like you can see the tilt of the teeth that came in as a result. Yeah. So most likely these were removed later in life. Furcation involvement, once we have enough recession, this is a problem. That's a high risk area for decay. You know, our hygienists should probably get pretty good about putting that in their notes. But likewise, we should get very good about talking about furcation involvement as a problem, even though there's no decay in those areas. Anybody want to talk about this thing right here? What does this tell us? How about this? Is that wear? Or even better, is it attrition, erosion, or abrasion?
It's pathway wear.
From like kind
Or is it chemical erosion because it's like bold or I don't know, spooned out or something?
Can we look at it from an occlusal view?
Jason got it. So when you see cupping, so you called it
cupping, that's it. Yeah.
Up like a bowl. When you see cupping, the only way you can get cupping is when you have a chemical erosive component associated with it. A wear facet, which is flat, indicates wear or attrition. Abrasion would be toothbrushing. Obviously, that probably has a small part to play in here. But when we talk about wear, there's attrition, erosion, and abrasion. When we see cupping, it's attrition and erosion, and probably a small bit of abrasion. What should we do when we see this?
Well, that's an indication for acid erosion, like you're just saying. So that's guys is back to airway, sleep issues.
Do we test the saliva or something? Can we do that at our office?
Yeah, we do. Chantel does a salivary diagnostic appointment. If you ever have a patient that has high caries risk or has head and neck cancer radiation, I do want to get to a point where she does it on all patients. We just haven't gotten to that point. But in there, one of the tests is pH, so you can measure the pH, and it also measures buffering capacity. So there's two different tests that would tell you what is the chemistry of this guy's saliva that may or may not lead to this being a problem. It could be erosive from external situations also, but we tend to see people who chew on lemons. It presents very different than this. This is definitely an airway problem, like Luke said. Patients who struggle with breathing because their tongue is too big. We can see his tongue is too big. It's scalloped. When we struggle to breathe, we're in a more sympathetic state. And when we're in a more sympathetic state, our stomach constricts more and it pushes the acid back up into our mouth. So we're more likely to have this. Not everybody who has acid reflux has heartburn. What's the condition called that I'm alluding to? Annette Stevens was the most outstanding example of this of all time. Silent Gerd. So silent acid reflux is real. Our patients may not know they have acid reflux. They don't necessarily taste the saliva. They don't have heartburn, but it is a reality that we have to account for. All right, so there's the occlusal view. A few more things here. What do we see?
Worn crowns.
Narrow, normal, or wide palatal vault?
I think it looks wide.
Wide.
I don't.
Wide.
Yeah.
Yep.
Shallow.
Yep.
Yeah, it looks shallow and wide.
If you guys remember from his initial photos, his nose had very large external nasal valves. Not surprising considering the fact that he has a developed maxilla. The palate is the floor of the nose. It's the same bone. So if you have a constricted palate, you have a constricted nasal passage. Here, if you have a wide one, you have a wide nasal passage. So not a problem.
It kind of sucks that he has such a good nasal passage, but down the pipeline, it's getting blocked likely.
He might, you're right, his external valves are large, but his internal valves or his turbinates might be obstructed, which we're not going to go into. I didn't want to bring the CAT scan in because I didn't think we had enough time tonight.
Yeah.
You know, I want us to stick to an hour because I don't want people to not show up because we end up spending 3 hours every Monday night. You know, wearing through porcelain on PFM crowns is a problem. You know, that's not normal. I remember taking a spear course and he spent like 5 minutes drilling into our head. When you see wear, remember that is not normal. And he kept like saying it in different ways and building value. I don't think in dental school, like when I graduated dental school, I just thought wear was something that just happened with age. And maybe they articulated it, but my perspective was that's just normal. You know, you go in, you do an exam, they don't have any decay. We've all done it. Everything looks good. Does it really? You know, their teeth are falling apart biomechanically, but just because they don't have caries, you know, we fall into that trap. It looks like he's chipped off the distal of number 15. He has balancing interferences on his cuspal inclines. True or false, that could be related to TMD. The answer is sometimes. When we have cuspal incline deflective occlusal surfaces, that the T-scan would pick this up. On the T-scan, we would see muscle activity when this comes into contact. Why is that? The incline means that when this tooth comes into contact, there's a horizontal vector of force that's picked up by the proprioceptors inside the tooth in the PDL. That has an immediate response in the peripheral nervous system to activate the masticatory system even more. So it has been shown that incline contacts, especially when they're deflective, in many patients can cause TMD, and it can cause myofascial pain disorder. You remove these and all of a sudden the patient goes, oh my goodness, that feels so much better. So cuspal incline deflective features are a problem, not something I would necessarily do a full mouth rehab for, but it is a contributing factor.
Yeah, like Roy, when I see like number, I don't know what I'm looking at here. I guess that premolar, he's got 3 of them on the right side. When I see a cuspal incline interference like that, like not that one, but the middle one. Yeah, like when I see that spot, not even just how dark it is, but the fact that it's occurring on an incline.
Yeah.
Those are the types of things that when I T-scan a patient that stick out.
Yep. What do you sometimes see on the T-scan?
I mean, I'll see that's usually a prematurity, but even if I don't have the T-scan, available, I mean, that's something that I'm usually trying to get more on the lingual cusp tip.
Yep. Awesome. What do we often see with these, especially on upper premolars? Not fractured teeth, although that is very common. So if we have a horizontal vector of force, meaning when the patient bites down on this point right here, right in the central fossa, the force is directed vertically down the long axis of the tooth. But if you bite on an incline, you then introduce a horizontal vector of force, which is the problem. That's when we see abfractions. So when you see abfractions, have them tap, tap, tap. 9 times out of 10, you're going to see an incline deflective feature to their tooth. When is this important? When you do a class 5 restoration, always adjust the bite. We didn't put any composite there, but the reason why we're restoring the tooth is because of a biomechanical problem that led to an abfraction and maybe decay, aesthetic compromise. But the problem actually exists on the occlusal table. Have them tap, tap, tap. And oftentimes you want to put your finger here and hold the tooth, because they'll often have fremitus or movement, and that fremitus often translates into the ink not getting transferred to the tooth. So hold this down while they tap, tap, tap. You'll often feel it deflect, very common with number 8 and 9. Then you'll get the marking on the tooth with the articulating paper, and then you remove that occlusal interference. So more of the same here. I mean, overall, this guy's, Dr. K did some good dentistry. He just probably didn't know how bad this guy's airway was. This guy lived in a sympathetic state most of his life. And when we live in sympathetic states, we grind more. So this is the rest photo that we talked about. All cases start here. That is the SPEAR algorithm. EFSB is the algorithm they use. We're going to talk a lot about that. But we want to know where his teeth live Let's see. Like that. Are his teeth here? Or are they here? Let's say his teeth are here. We're going to want to lengthen when we decide to do his wax up. We have to tell the lab. The lab doesn't know this stuff. So we send out diagnostic models to the lab. We may miss the point that the lab has no idea where to put the teeth, so they just lengthen them. Well, what if the teeth were here? You don't want to lengthen those teeth. So you have to tell the lab where to put the wax, starting with this photo here. And it's the presence and wear cases that we need a tool. I currently use a perio probe, and I put it on the incisal edge, and I measure to the rest position of the lip. That Luke is going to develop a tool for us to be able to do this, or have Chantel do it, and then we'll have it in this photo. We'll just have the ruler coming out. So that's pretty much it. I had a lot more I wanted to go over, but I think we're gaining some understanding of what we're trying to do, in that we're trying to be thorough about all of the problems that might exist in this guy's dentition. So maybe next week we can start talking about some treatment strategies, and then the week after do a phase plan. Thoughts, concerns, questions, tomatoes?
Yeah, I think it's awesome. I mean, I like even just that little tidbit about the abstraction and adjusting the occlusions, just mind blown. So this is exactly. I mean, this is great.
Awesome. Google.
I do have a question, if you don't mind, real quick, Nick.
Yep.
When you say automation, down the road, do you envision a program like machine learning, something where you're checking boxes, these are all the diagnoses, these are all the problems, and then you have a place to start treatment plan wise? That's the down the road goal kind of thing?
Yeah. Luke and I sat in the hot tub Saturday night for 2 hours and talked a lot about that. What that could look like. And maybe we delegate that to staff. At the end of the day, Luke, how many treatment plans have you done in the past year and a half? I
don't know.
It's a lot.
It's scary.
The workload is immense. And Greenbaum's first foray into this was, but patients aren't signing up. He was getting kind of concerned that he was putting all this work in and nobody was signing up.